Good morning, everyone. Thank you for joining our meeting today. Today we have Professor Gregory Basura from Pittsburgh, who is our guest presenter today. He's going to present on chronic otitis media and mastoidectomy techniques. Hopefully you can go ahead.
Okay, great. All right, I hope everybody can hear me. Okay, excellent. Well, thanks for giving me the opportunity to speak today. I figured this was a good topic for the collective because chronic ear disease is very common, and there's more than one way to manage this, but obviously it's very important because of the implications that it can have. So we'll talk about what is chronic otitis media and then how do we manage it, not just surgically, but medically as well. So let's move this here. Okay, so chronic otitis media is really a spectrum of disease. It's important that we understand the nomenclature of this because you can see all facets of from normalcy, from a normal examination to various stages of ear disease. So chronic otitis media can take very different forms, but it's really important to kind of get a grasp of what the different varieties are because it has implications about management and an appreciation for disease state. So you can see things like this where you have what we call chronic adhesive otitis, where the drum has been adherent, it's shrunk wrapped, it's stuck down to the underlying structures. So other things that could lead to various states of infection superimposed on chronic change. So it could be a fungal infection, it could be a bacterial infection on top of already chronic change. So chronic otitis media is really defined as any structural change in the middle ear system associated with a permanent defect in the tympanic membrane. Okay, so that's how you define it. And then that change has to have been occurring for at least 3 months. So if it's less than 3 months, that's not chronic otitis media. So chronic otitis media can take all kinds of forms. You can have various forms of tympanosclerosis. You can have various forms of perforation or myositis, inflammation. There's usually, in addition to the findings of the drum, you're going to have some kind of concurrent middle ear or mastoid mucosal disease. That's usually what we would consider to be probably the underlying or the inciting event that's led to the change you're seeing at the drum level. And so that can take various forms. If it's chronically draining, we would describe this as we start to add more descriptives to the situation. Chronic suppurative otitis media or frequent or persistent otorrhea through a tympanic membrane defect. Remember that anything you see that's greater than 3 months would be construed as chronic otitis media on this spectrum of disease as you start to think about that. So TM perforation classifications, we all see these. This would fall under the auspices of chronic otitis media. So typically, if it just involves the pars tensa or the central portions of the drum, we would call that a central perforation. These do not extend all the way out to the annulus. So they're usually housed within the pars tensa. And so these are rarely associated with cholesteatoma. So some people consider a perforation like this to be generally a safe ear, meaning you're going to have less opportunity to have migration of skin along the canal in through that perforation into the middle ear. And typically, if they're infected, you can treat them topically. Repair is often elective in these situations. Again, this is a safe ear. If it's not draining, you can watch these. You have to make a decision. I always talk about with patients back home, why do we repair perforations for 2 reasons. One, if it's chronically draining and they're getting infection despite water precautions. Or 2, if there's an opportunity that they want to improve the conductive hearing loss, then we'll repair the drum. But again, these don't always have to be repaired. And you have to think about this too, is that in many situations, people might have eustachian tube problems, they have middle ear issues, they have recurrent middle ear effusions, and many times the perforation is serving as a tympanostomy tube, right, without the tube. So they're actually ventilating their middle ear and avoiding middle ear effusions as a result. So what about a marginal perforation? These are construed to be a bit more risky because they extend all the way out to the bony annulus or to the annulus of the ear. And as a result, there's less barrier for migration of skin, say from the ear canal into the middle ear space. And so they actually can potentially be a higher risk of developing cholesteatoma or invagination of epithelium into the middle ear space. So these, you want to watch these a little bit more closely. Now, these are the ones that are often challenging. So when you're looking at an ear in the clinic under a microscope, many of these patients might have a marginal perforation in the anterior inferior quadrant. And there's a large canal wall hump. So many times you can't actually see the full extent of the perforation, and you can't actually see if there's migration of something in there. So these can be challenging to follow clinically because of the nuance of the anatomy. But you do have to follow these, folks. You should, and I always counsel them keep the ears dry. But if I'm going to repair perforations, these would be more that I'd be a bit more advocating to repair than the ones that are central because of this possibility of it being an unsafe ear. Okay. Now, what about pantympanic membrane perforations? Well, we've seen these. A lot of folks have seen these, and I've seen these in other parts of Africa where basically the entire drum is missing. You might have a little rim of annulus all the way around, but essentially the bulk of the drum, with the exception of maybe a little bit of the pars flaccid up by the lateral process of the malleus, is the only thing that's present. But you're getting this panoramic view into the middle ear and the underlying structures. These are typically safe, right? Because the idea is that everything is exteriorized. The chances of developing trapped skin or squamous debris in there is extremely low. But you have to think about repair on these. Now, again, you have to think about what the goals are. Because if it's a safe ear and it's not draining, obviously the repairs would be to improve hearing. But if it is draining, that would be also the goal here. But again, these don't necessarily have to be repaired. A lot of people now are using bone-anchored hearing aids, whether they're soft band or surgical bone-anchored hearing aids that can bypass the conductive loss and restore hearing. So in that same consideration, you don't necessarily have to repair these, but and of course, these are more challenging to repair, but by typically they're a little safer. Again, all of these conditions of perforation fall under the same rubric of chronic otitis media. Okay, so these are typically forms of chronic otitis media. So an important distinction that you're going to make in someone who does have a drum intact is it atelectatic or adhesive? This is an important distinction to be made. And so I'm always telling trainees that I work with that you have to examine all these ears under binocular microscopy, and you should do pneumatic otoscopy to see about the drum mobility. Why is that? Well, in the upper portion of the drum, of the picture here, the drum, you can see that it's kind of collapsed. It looks thin. You can see that it's maybe shrunk wrapped a little bit over some of the acicular chains. Some people call that maybe a moringostepidiopexy. The idea is that if under negative pressure, if you could pull the drum off of those underlying structures, it means it's not quite adhesive. It hasn't stuck down. It's atelectatic. It could be very thin. That tells you that there is change in the drum, but it's not irreversible at this point, to the point where you couldn't salvage it with maybe a pressurization tube. So the idea is if you put a tube in the air, you might be able to restore middle ear pressure, positive ventilation, and prevent this from evolving into further an adhesive drum. So if you don't perform negative pressure pneumatoscopy, you'll never know if that's mobile or not necessarily. But the drum is very atrophic. And you may find that even making small incisions of the drum, it's very wispy. It breaks down, it falls apart. It may not even be able to hold a tube for very long. So these are challenging ears. It means they've been under negative pressure for a long time. Now, contrast that with adhesive otitis. Now, clearly, you can probably, just looking at that ear, think about what it would look like under negative pressure pneumatoscopy. All that stuff is shrunk right down. That's been negatively pulled down for so long that it's now adherent to the underlying structures. Believe it or not, as ugly as that ear is, it's very safe. That actually is a very safe ear. So the point being here is that under negative pressure, if nothing elevates, you might get some mild elevation down here near this inferior quadrant. Putting a tube in there is not going to change that ear. So there would be no point in doing that. So the value of doing positive negative pressure pneumatoscopy in the clinic tells you this difference, whether or not maybe a tube would be helpful or not. So in this situation here, now if you got chronic adhesive otitis and it's shrunk wrapped down, at that point, you really have to make a decision. You have to say to the patient, well, it's safe. You're going to have conductive loss, but you have a safe ear. The alternative to fixing that is not trivial, because you have to go in and clean all that skin out, remove the drum. And if you don't remove all skin and you repair it with a graft, you're going to risk an iatrogenic cholesteatoma, right? There's a high likelihood you're going to leave skin behind, then you're going to trap skin, and then you're going to create a bigger problem down the line. So the issue here is when it gets to this point, many times you just have to tell the patient it's safe, you got to keep it clean, and then we have to kind of figure out a way to deal with the hearing loss, maybe a hearing aid if that's an option. Okay. So So that covers part of the drum. Now, what about cholesteatoma? So obviously cholesteatoma can be an underlying cause for a lot of the things that we might eventually see that manifests as chronic otitis media. Certainly can be acute otitis media. Now, we all know cholesteatoma basically is a fancy term for skin in the wrong place of the ear. So keratinizing squamous epithelium within pneumatized spaces of the temporal bone. And some of these, I don't do so much peds anymore, but for those that are involved with pediatrics, you may see congenital cholesteatoma. Obviously, in a non-operative ear, no traumas, no tubes. You may see a whitish mass in the setting of conductive hearing loss on exam, and that can be in keeping with congenital cholesteatoma or trapped rest cells during embryogenesis that have not involuted, and then they deal with this. So this becomes a surgical problem, but you have to be very aware that on physical exam. Most of the stuff we deal with is acquired, right? Acquired cholesteatoma, right? So we're going to deal with various forms of acquired cholesteatoma. And some people use the primary, secondary nomenclature. I don't typically use this. Most of the things we're going to probably see are going to be attic defects with intact pars tenses because of the nature of the pars flaccida being two layers. It's going to be more apt to get sucked into the midler space and prosthetic space and pull skin up into the attic, versus a secondary, which would be maybe more of a pars tensa defect. I don't necessarily use those two nomenclatures. I'm more just descriptive on where we're seeing the defect. Okay. So acquired cholesteatomas, they can evolve over different forms. I think the keys, again, that I would impart when you're examining these ears in the clinic is to take a close look at any crusts or any defects that are up high near the scutum or the attic. Many times if you see like a redness here or almost like a meningitis or an inflammation, if there's a crust over that area, you need to remove that in the clinic because invariably there's a defect and skin has migrated through there and eroded that and has led to infection that is then dried, and that's what you're seeing. So these are various forms. Some of these actually are fine. Some of these attic defects, if they're clean, you can keep them clean, and those don't require surgery. But the deeper they go into the ear, and if you're actually removing keratin debris from those areas, that is going to be a surgical problem. So on these, the take-home point here is you're going to have various findings of defects. You need to identify those clearly in the clinic. And whether or not they are surgical or not will really depend on what they look like. These first couple here, I wouldn't necessarily would say are surgical. This may not even be. It just depends on how much debris is accumulated over that time. So other things that we talk about that may be misconstrued with cholesteatoma, that when you're taking a look initially, or your primary care colleagues are looking and they think, oh, that looks like cholesteatoma, is various elements of tympanosclerosis or scarring of the drum. Okay, so we've all probably seen that. And at first blush, when you first look at this, you think, oh, that looks like cholesteatoma, but no, it's not. So under gross or binocular microscopy, and you take a good look at the ear, you can see that actually that's embedded in the drum. And actually, when you move the drum with positive negative pressure pneumatoscopy, it actually moves well. So you have to be very astute when you look at these, because you don't ever want to. I'm sure there's cases where people have taken those folks to the OR thinking it was cholesteatoma, and it's actually just advanced tympanosclerosis. So these can involve the middle ear. I've seen these where they actually invaginate in the ear, and you get like plates of bone that then envelop amongst the ossicles. So these folks can present with significant conductive hearing loss. And this is not a trivial disease process to remove from the ossicles, especially if it gets around the oval window foot plate near the stapes, and even right into the clefts of like the oval window cleft or the round window cleft. And so this, you have to be very, you have to make a good decision about risking damage to the inner ear if you're going to go to try to remove that. But the key here is the diagnosis of this, and not assuming that that's cholesteatoma. Okay. So the hallmark, the things that we use mostly, I would say, when we're looking at otology and ear disease, when we're diagnosing it, in addition to just our good physical exams, good clinical exams with binocular microscopy, pneumatic otoscopy, really good tympanometry, looking at drum mobility, plus or minus acoustic reflexes, is radiographic studies. And most of the workhorse would be CT scans. This is kind of the gold standard, right? Because the CT gives us really good resolution about bony anatomy and the relationships of the bony anatomy to the other underlying structures. Now, remember, and I know that this audience knows this, but remember that we really can't diagnose cholesteatoma with a CT scan, right? We can with an MRI with diffusion weighted imaging, but we can't with a CT scan. So this is an adjunctive tool that you're going to use in addition to your clinical exam to make a determination. So remember that soft tissue, an absence of soft tissue rules out a cholesteatoma, but the presence of a soft tissue density still makes you wonder what it is. Is it cholesteatoma? Is it brain? Is it cancer? Is it some other structure? Is it wax, etc.? So the CT lacks the specificity for that, but what you're going to use it for is an adjunctive. So always get non-contrasted CTs with temporal bone configuration for fine cuts. Now, if you have a situation like this, which is a coronal image of the right ear, where you clearly have a tegment defect with a soft tissue density that's contiguous with the intracranial cavity, you don't know what that is, right? You might think that that could be cholesteatoma that's eroded the tegment, but how do you know that's not frank encephalocele that's now temporal lobe that's now involuted down into or evolved down into the mastoid itself? So in those situations, an MRI would be required to look for that. Now, when I personally get CT scans is when I'm looking at anytime I'm going to revise surgery. So if I'm seeing a patient that I've not operated on that needs surgery, I'm going to get a CT scan because I don't know what's going on in there and I don't know what changes have transpired. In this scan, this is an axial view of a right ear, and you can see that there's a lot of things going on. First of all, we've got an underdeveloped mastoid that's partially sclerotic, partially opacified. We've got a soft tissue density within the previous mastoidectomy site. We've got new bone growth here, which is interesting, right? So that means that the body's responded. There's new bone growth, which you wouldn't necessarily appreciate on the clinical exam. And depending or not, maybe with the audiogram, this person's got a horizontal canal fistula, right? So they may have a dead ear. They may have complete hearing loss. But before I'm going to go operate on that person, I really want to know what some of the underlying anatomy is so I can be prepared for other things. And again, this is where it's interesting because obviously you may not have a CT scan available to you, right? So you have to figure out, whether or not that's going to be available to you. If not, you have to think about other diagnostics that are at your disposal. Getting the audiogram, maybe looking at fistula tests to look for, is there some kind of a fistula? Maybe a bedside or chair-side vestibular exam, right? Looking at head thrust exams. Do they have a peripheral vestibulopathy? Obviously, you're going to look for your cranial nerve exams. If they do have cranial nerve fallout, so facial paralysis or something, that may warrant imaging. Definitely would want to get imaging if you haven't already. And of course, anytime there's a CNS complication, right? So if you're concerned at all about previous meningitis or any other neurologic deficits, I definitely would try to get scans if you can get those. So the MRI, again, this is, again, plus or minus when you actually need it. A lot of nonspecific findings in chronic otitis media, right? So now with the advent of diffusion weighted imaging, people are using that to surveil for possible cholesteatoma, which is nice. Whereas before, you'd have to do a lot of second look surgery or assume-based change on CT scans. But an MRI with DWI is nice. Again, the MRI is you're going to see some enhancement with gadolinium around the matrix, but again, can be non-specific. But again, most of the time I'm getting an MRI is if I'm concerned about, is there an encephalocele? Is there some kind of CNS complication? We don't see a lot of brain abscess. I know here you see a lot of intracranial complications from acute mastoiditis. And obviously that's important here because if someone's coming in with altered mental status, spiking fevers, neurologic findings, you need to get an MRI because they may have a brain abscess, right? Not necessarily probably see with a CT, but ideally an MRI would be much better. So when we talk about chronic ears, people coming into the clinic, obviously there's some management that needs to be done up front. So many times the patients come in, not going to immediately just whisk them right off to the OR, right? So this is oftentimes what you're going to see. Patient comes in, they've got a draining ear, they might have hearing loss. It could be progressive, they've got fullness. And when you look in the ear, you see this big fleshy red mass in the canal. Now, the differential could be wide on that. Things you have to think about. One is this an oral polyp? First of all, is it inflammatory? Is this an inflammatory cap over something that is causing this? Is it cancer, right? Obviously, it could be squamous cell carcinoma, right? Usually that presents with pain. In diabetics, it also could be something like, acute necrotizing otitis externa, right? Or malignant otitis externa, right? So you have to think about what your differentials are. Are they diabetic? Is it painful? If they had chronic ear disease? And then do a really good exam where you can maybe suction around this area, remove part of it, remove some of these if it's possible to see where it's pedicled. And then typically what I would do first, unless I can see it, is I'm going to treat it with topicals. So usually we're going to use some kind of topical antibiotic, maybe ciprofloxacin with maybe steroids, and then bring them back. Again, this depends on what the availability of patients being able to come back are. Otherwise, you may have to just debulk this to see what's further down in the ear. These ideas about chronic granulation tissue, you have to think about why are they having chronic granulation. We use a lot of vinegar, acetic acid, vinegar and water irrigations in the ear, which is really nice because it rinses the ear, but it dries the ear. So that's something you can do. For folks that have chronic meningitis or drainage, some people use gentian violet, which is a desiccant. You can use boric acid. Obviously, if it's chronically draining in terms of it's purulent, you have to worry about multibacterial resistance, right? So the idea is maybe getting a culture and then culture driving your treatments. Now here, obviously in Africa, where in the States, we don't see TB in the ear. I know you guys will see TB, right? I've never seen TB in here outside of the US. So the differential, again, you have to think about it situationally, regionally, wherever you are, right? Probably never seen TB in the ear in Belgium, I imagine, right? Probably not, I imagine. So it's different depending on where you're practicing. So you have to think about those differentials, right? So the ototopic agents, again, these are variable, and I'm always interested to hear what people use around the world, but a lot of fluoroquinolones. Why? Because a lot of disease in the ear is Pseudomonas based. We see a lot of Pseudomonas, gram-positive things too. So we use a lot of fluoroquinolone based treatments. So ciprofloxacin, ofloxacin, plus or minus steroids. So the idea of steroids on top is particularly if there is inflammation is really important to kind of cool that off in addition to treating the underlying problem. In those situations that people develop some resistances, sometimes there's Tobradex, there's different variations that we may have to use. I try never to use the aminoglycosides, obviously, particularly in somebody who has a perforation, right, for obvious reasons. We don't want streptomycin, we don't want gentamicin in the ear for obvious reasons, for hearing loss or vestibular toxicity. Even polymyxin like neomycin. Some people use these things called corticosteroid drops. Sometimes those will get put in the inner ear through the canal, but with a perforation, those can be ototoxic. So you have to be careful about what you're putting in someone's ear. It could be actually doing more damage than you think, especially if you have a perforation. And then sometimes it may not look like you have a perforation when you suction the ear, but the ear's filled with purulence, and you look in the ear and there's no perforation. You have to think, well, where's that coming from? So they may have a small perforation you can't appreciate. So you have to be careful about what you're actually putting in someone's ear, because that's just something that that can do damage. So medically management, this is variable. I mean, I'm going to see somebody comes in with this polyp in their ear, and I'm not worried that it's a cancer or like a malignant otitis externa. I'm going to try to treat them first for maybe 2 weeks, bring them back. If that is still persistent, I'm going to debride that. I'm going to send it off to pathology. I'm going to debride that. If it's even more complicated, I may get a scan and then have to take them to the operating room. But the important thing there is to not let these folks kind of drift for too long, because obviously something's causing that inflammation, and most likely it's going to be cholesteatoma. So so you treat them, bring them back, try to keep the ear dry, and then a lot of folks will still have otorrhea despite the treatment. So you have to think about what's actually going on there. So surgical management, again, this is where things are varied, right? This really depends on what the problem is, right? So if you have persistent otorrhea, if you have irreversible soft tissue disease, I have a patient that I take the OR she's otherwise healthy, developed acute otitis media 6 weeks ago, has been on 6 weeks of antibiotics. The drum continues to be thick. The scan shows some complete opacification in the middle ear. So in this situation, I've got to take her to the operating room, just simply open the mastoid, clean out probably like a lot of granulation tissue, and figure out what's actually going on. So sometimes the surgical management of these diseases actually diagnostic, because sometimes patients can have ongoing inflammation of the drum or the middle ear space, and you don't have a good explanation, and they've been on antibiotics for many weeks. You might talk to your infectious disease colleagues and they say, well, we don't really have anything. Instead of just using something broad spectrum for weeks and weeks with IVs, you may actually have to open the ear and then get more tissue to determine what's actually happening. Obviously, if you have cholesteatoma, this is obviously a surgical problem. I just mentioned granulation and mucosal disease. So the goals of surgery are always important, right? So we have this ladder of thought. So typically, when you think about what are the goals of surgery, obviously safety is first, right? We're trying to rectify some kind of create safety, right? Whether it's cholesteatoma or cancer, right? You're going to rid the disease. Whereas then function becomes secondary. Even though ideally the goal would be to retain hearing. The idea is that becomes a secondary goal and secondary to safety. And of course, intracranial or large complications, those always supersede any other goal. So ideally, we'd want to create a safe, dry ear. You want to try to restore hearing and retain your anatomy. So approaches will vary, and depending on where you're trained, again, some people will do end-oral incision. We do a lot of post-auricular approaches because many times there's going to be drilling that's going to be required of the ear canal, whether it's canalplasty plus or minus mastoidectomy. So the post-auricular approach, many of you have been familiar with. This provides you not only access, but also gives you opportunities to use tissues in your repair. One thing, a little pearl that I've learned along the way is when I first started my practice, many years ago, I would kind of assume what I would need. And I would take some of the tissues and start drying them, pressing them, getting them on the back table. And at the end of the case, when I'm closing, I would find I was wasting so much tissue. I was like, I didn't need to take that much. It was a waste. And many of these folks might need revision surgery. So what I learned over the time was I take those tissues that I need at the end after I fully know exactly what I need. Then I go get what I need. Okay. It's kind of like going to the grocery store when you're hungry, right? That's not a good idea, right? You're just going to buy up everything and you're probably going to waste half of it, right? So go when you need something, not when you're hungry. So the idea is that when you know exactly what you need is my point. So these are great. So post-auricular incision, we can get temporalis fascia, we can get pericranium, we can sometimes use other tissues as needed. Of course, we know the mastoid approach, right? So typically a lot of our work is going to be through this corridor, plus or minus wall down. We're going to talk about that shortly. But the idea is, again, depending on your training and your comfort level now, with a lot of people doing endoscopic ear surgery, a lot of people are bypassing some of these things going behind the ear. They're going transcanal, they're lifting flaps up with use of endoscopes, right? Which is nice, which is a good thing. But I would say the bulk of my surgery is from the post-auricular side, and I usually don't make an incision on the anterior canal side before I enter the skin. So usually make incisions behind as I go down the canal. I'm lifting up, and as I see the skin, just as it's starting to curve away from me on the bony annulus, then I make my canal cuts in the skin. And make these cuts on basically at 12 o'clock, 6 o'clock near the tympanosquamous and tympanomastoid suture lines. And then use a Penrose drain. I like to use a little Penrose through the canal, and it pulls everything forward. So the advantage is that it does save some time. You're not having to go make cuts here and then go find them. Again, usually only healthy skin in the flap, which is nice. You're raising it as one contiguous flap, and then you cut. If it does tear, you can just cut it there and then move forward. The disadvantage is it's hard to tell your depth. Again, this is where some people now use endoscopes more and more, which actually they can make the cut right where they want, lift it, and that's fine. So in that sense, it can be more challenging. But the more you do this, the more you have an understanding of the depth. So once you've done this, once you've opened the middle ear, you've lifted maybe a tympanomeatal flap, depending on what you're doing, you may or may not need mastoidectomy, right? So again, with endoscopes also, I would argue now, are changing the way we manage disease. So now with angled endoscopes, you can do glorified adichotomies. You can remove more sputal bone, and you can actually look up back toward the antrum from the canal side. And with angled instruments, you can actually remove disease now, whereas before you have to perform mastoidectomy. Because now you can get that antral side as well if you don't have endoscopes. But even with endoscopes, I would argue many times you may still have to have this. So cortical mastoidectomy, obviously it's important. I'm always going into every case trying to preserve anatomy. So if it's cholesteatoma, my whole goal is to retain anatomy and keep the canal intact, unless there are hardline indications that I have to take it down. But I always have a conversation with the patient about wall down cavities, the need for a canal wall down surgery in the event that it does happen in the OR. And when I first started, I didn't have that discussion with a couple of patients, and I realized I needed to take a wall down, and either had to go talk and clear with the family, or we had to wake the patient up and then have a conversation and then bring them back at a later time. So I think it's really important to have those conversations up front. Again, it's preference, but I think it's really important because you don't want to get into a situation where you need to do something and you didn't have a conversation and you didn't consent the patient for that. So that's important. So, but again, with endoscopes now and better visualization, I think we see less and less of that. So obviously the importance of a wall, the canal wall, intact canal wall is visualization, right? So you have to thin the canal. So these are some different artist renditions showing the nature of what you're trying to achieve. From this side view, obviously you really got to get a thin ear canal. So the key on the canal wall is a thin ear canal. You don't always have to open the facial recess, but the point here is a nice thin ear canal so you can see clearly into the antrum and disease that may be tucked tightly into the antrum. When we're opening the facial recess, so these are just some concepts that we use they're my training about how we describe some of the anatomy. So this is an example of a right ear showing the short process of the incus. Here's the mastoid antrum. Here's the root of the zygoma. Here's the bony ear canal. And we've thinned nicely the ear canal. And now we're working right over what's called the facial recess or the posterior tympanotomy. We use, at least in my training, angles A, B, C. It's nice when you're training residents or trainees to tell them to direct them, because otherwise you're saying, well, go to where the chorda and the facial are. Right? It's easier to just say angle C, right? So this is some nomenclature we've used that fits nicely with what you're seeing here on the anatomy. So angle A is in the anterior component up here, and it's basically superior and lateral to the second junior of the facial nerve. This would be the safest area of the angle of the triangle. Angle B is where the nerve is turning. So this is probably the most dangerous of the three angles. You never want someone to be drilling 90 degrees to this because you're becoming 90 degrees to the facial nerve. And then angle C is obviously where our chorda takes off here from the facial nerve. So angles A, B, C are a nice way to describe this. And many times we have to open this because if we don't have good access and we're trying to retain the ear bones, we're trying to get into the middle ear, maybe to clean out some of the sinus tympani of additional skin. Obviously, this is our approach most likely to use with cochlear implantation, right? So most common reason we open the facial recess is for cochlear implantation, right? So I always tell trainees that facial recess is like a mastoidectomy within a mastoidectomy, right? It's just a mini mastoidectomy. So it's lots of water, it's long strokes paralleling to dangerous structures, okay? So again, the point of this here is thinning of the canals, right? So I would argue that if you can do this kind of surgery here, if you can get the mastoid open safely, you can thin the canal, you can maybe open the facial recess, you can see into the antrum, and you've got a nice tip of the metal flap lifted up, you can do pretty much 90% of mastoid surgery, I would say. I mean, then you pretty much have done the heavy lifting, right? The wall down, I mean, we'll talk about that shortly. The next part would be taking the wall down, but really you've done the bulk of what you need. You can safely identify facial nerve. You can safely not get into the tegmen, not get into the sigmoid sinus, not get into the labyrinth, safely open the canal and preserve these structures and work in these corridors, then you've really done the bulk of what you need to do. The rest of it will be, additional things, but this is really the heavy lifting. So it requires practice and skill, requires thinning the canal, trying to avoid, don't be your own worst enemy. So things that people do that can come back to haunt you later are putting holes in the ear canals, right? If you punch a hole in the ear canal, you think, oh, that's fine, we'll just put something over it. Well, over time, that can create a ear canal mastoid fistula, right? Or it can create a canal cholesteatoma. a lot of patients after they've had ear surgery, then you think, oh, I'm done, I'm good, I don't need to come back again. The next thing you know, they come back, but they don't come back, and they've got this brewing problem that surfaces years later. So be aware of these things. Thinning the canal, thinning the skull base. You got to be able to see the big tenets of surgery that I always tell the trainees. One is you never drill under an overhang. You never push a drill. Okay. You always use the largest burr that safely fits. Okay. So these are things that you got to be thinking about when you're drilling a temporal bone. Okay. So this just shows now the advantages of the facial recess. So now we've removed the incus. Right now you're seeing the residual malleus. Here's stapes. Here's the round window niche. The idea here is this is just for exposure, for access, right? And many times, as you know, Lillian, you and I were talking about this yesterday, is, you know, you may have to come back. I mean, again, some of the things that we do surgically in different parts of the world are not necessarily done elsewhere, where many of my patients that have a first surgery, because of the high recidivism rate of cholesteatoma, we have to bring them back for a second look surgery many times, right? So maybe 9 months to a year later, you have to bring them back, check for recurrence, and maybe rebuild the ear bones. That may not always be an option for you. So you have to think about, what is it that I need to do at this to help the patient now? Am I going to be able to see them again? And what is going to create safety? So many times you may have to open the facial recess. You may have to remove the bulk of the ear bones. You may have to do a limited reconstruction of the ear bone chain using cartilage. So there's a lot of intraoperative decision making that is relevant to the anatomy and the disease, but also to social situations, whether you're going to see the patient back. So obviously there's advantages. There's advantages to the intact canal wall tip panel mastoidectomy, and this is what you should see at the end of your case, right? So the advantage is there's no mastoid cavity, so they don't have to manage the bowl with hygiene at home. They don't have to come see you a couple of times a year to clean the bowl, right? So obviously there's faster healing. There's no water restrictions, and it's more accommodating for hearing aids if they need them. Okay. The disadvantages, though, is it can be sort of a ticking time bomb, right? There's a higher risk of recurrence. Now, ideally, hopefully less now as people are getting more sophisticated with endoscopes. They can clean around nooks and crannies and these types of things. But residual disease is really hard to oftentimes to get out. Remember, if you leave one skin cell behind, it's going to come back. So under these little nooks and crannies near the antrum and in the sinus tympani, you can leave disease behind that is going to need to be cleaned out later, right? So folks that have recurrent disease due to continued eustachian tube problems or other underlying problems that have gotten them there to begin with, that can come back as well. And then, of course, these early recurrences may go undetected. So some of these folks, like I said, may be lost to follow-up. And then they come back later with a draining ear, or maybe they've developed something like a intracranial abscess, which would be, you know, obviously on the far end of the spectrum. So again, pluses and minuses here. Again, my goals, I always try to retain anatomy, but again, I'm always thinking, what's the next step? What's down the line? What else could possibly be coming? So think about that as you go forward. So the ideal candidate for this is usually a well-pneumatized mastoid that's aerated. Again, I'm always interested to hear, maybe we have a minute to hear from people on the call. How many people take folks back for a second look surgery? What's the standard of care in a lot of places? Do you get a CT? Do you say, okay, we're going to take you back in 12 months? Do we just follow you and then see what it looks like? So these are the types of things that are really variable. A Bondi mastoidectomy, this is kind of a fallen out of favor concept. This was kind of under the rubric of a modified radical operation. This was typically only used to treat isolated adipoantral disease, and it's usually just lateral to the ossicles. So this was something that people would do where they basically just exteriorize the canal. They would do like a little exteriorization, like an adicotomy, and things would be exteriorized. These are pretty rare to see because it's rare that because the middle ear space is usually not entered. So it's pretty rare that the disease is usually not in some form of the middle ear space. But this is just the nomenclature where you actually would just kind of do a little exteriorization here. That's nice because you've gotten to the disease early, but it's pretty rare that I find that you find that this is the only thing you have to do. Now, oppose that with the radical mastoidectomy, and I would argue that this becomes more relevant for chronic disease, folks that you may never see again, dangerous ears. This is your kind of your open mastoidectomy, right? So basically it's your intact canal wall that you just did nicely, and now removing that, right? So I find that it's tough to conceptualize with patients. What does this mean? People don't really quite understand when you say canal wall down versus intact canal wall. So one thing that I will use with patients is descriptive of a house, right? And say like a burglar in the house. So what I tell them is this: I say the house is your ear, the burglar is the cholesteatoma. So you're told you have somebody in the house, a robber in the house. When you come home, you got to find the robber. You have to go through every room in the house to find them, right? And it keeps happening. They keep coming back, right? Because there's a lot of rooms. You can't find them. Well, after a while, you finally say, okay, I want you to take all the walls down in the house. I walk in the house, I want to see from the wall, ceiling to the floor. That's the wall down cavity. So now when you walk in, the burglar's sitting right there. They can't hide. They're there every time you see them. That's the canal wall down. I use that as a concept to describe to patients, because otherwise it's hard to understand. What do you say? What do you mean the wall down? What do you mean the wall up? So I think it's helpful for patients to understand that. So the goal here is to exteriorize. So when we use buzzwords about cholesteatoma, the intact canal wall is extirpate disease. We're trying to remove disease, right? The wall down is an exteriorization. Now we're trying to exteriorize disease, meaning we know that the skin is going to be there. There's reasons why we're doing this, but we don't want to, we're creating a situation where the skin can no longer hide, right? It's exteriorized. So now when they come to the clinic, I can look in their ear. Okay, there's no place the skin is hiding. It's right there. I can clean out the debris and the garbage from the ear canal. Does that make sense? So extirpate versus exteriorize. And so the whole goal here with radical mastoidectomy is exteriorization. You are opening the mastoid, plus or minus tympanoplasty. That's harder because you've lost the middle ear height. Because as we'll see, there's three key things you do for a good wall down cavity. One is you've got to drop the facial ridge right here, right? If the facial ridge is too high, they'll trap the disease. If the mastoid tip is pneumatized, you have to remove the mastoid tip. If you don't, disease will get trapped into that, skin will grow into that mastoid tip and it'll hide, and you'll be able to clean it. And then the cavity chronically drains. And then the third is a generous meatoplasty, right? You guys have seen those probably, where you actually have to remove chondral cartilage. You've got to make the opening of the ear wider. The meatus has to be much wider. So the mastoidectomy goals here are different than when we just had with this. Now we're trying to just prevent disease from trapping. So the advantages: excellent exposure, reduced recurrence. You always avoid that. I would say you ideally avoid a second surgery, and it's cost effective as that result. It's good examinations. Disadvantage: now they got to come back and see you, right? They've got a bowl that needs to be cleaned. Okay. You water restrict. There's a big needleplasty. Some people don't like the big opening in the ear. Sometimes that can nose down. You gotta manage that. And as a result of that, they have limited options with hearing aids. But many people now are using bone anchored hearing aids because the reconstruction options are often less when you have a wall down. Okay. So the indications: limited surgical exposure, right? If they've got a really sclerotic mastoid with limited pneumatization. We've all seen this. We call these cue ball mastoids. It's like the game pool with the cue ball. If you cut it in half, it's like solid. Sometimes those bones can be just really solid, and you're having to do just kind of like an inside out wall down. If the middle fossa is very low flying and you can't get good access, you can't just keep the wall in place. If the sigmoid sinus is really far forward, you may not be able to preserve that mastoid. People will say cholesteatoma and only hearing ear. So if somebody's got a really bad cholesteatoma and only hearing ear, many will say you should take the wall down. Why? Well, because they may go neglected, and all of a sudden they show up because the other ear dropped. Their only hearing ear dropped because they developed a mastoid fit. They developed a canal fistula, like horizontal canal fistula. Now they got both ears are gone, right? So some people will say you should take the wall down, and somebody who has and they're only hearing ear. Obviously, if they have a labyrinthine fistula, you have to take that down because you're going to have to leave skin and matrix over that. If there's multiple recurrences, if they have a destruction of the posterior, like the ear canal wall or big scutal defect, Maybe it's could be after drilling. It could have been iatrogenic. Most likely, if it's recurrent. And of course, unwilling or able to have multiple surgeries, right? So I've had patients that very, very sick, they're very frail, and you think, wow, I got one chance to get them through anesthesia here. So that's one thing. You think, okay, I can't do second looks. I can't keep putting this person in anesthesia. The other issue would be is if you're worried about social dynamics, like, well, I'm probably never going to see this patient ever again. They're probably never going to have the capacity to come back. So you want to make it a safe year. Okay. So this is to reiterate. This just highlights what we just talked about. So to make it an effective mastoid, you got to get this facial ridge lowered, right? So you're right over the facial nerve. So they'll call that the beginner's ridge because many people don't want to get that aggressive over the facial nerve and a little nervous about getting too low and they don't want to damage the nerve. So they leave this ridge really high. But the problem is that creates a possible area where debris can trap. So you feel comfortable dropping that down. You got to remove this mastoid tip so that when the soft tissue comes down, now it closes and obliterates that space. Whereas if you didn't, you see that space back there, you'll collect debris and stuff. And then a large meatoplasty. The meatoplasty, this is just an example of how we do the meatoplasties. So to do an adequate meatoplasty, you have to remove cartilage. Okay, so Lempert incisions, lift the flap, and remove all this cartilage, and then this will heal this back. If you don't remove the cartilage, it will restenose or restart it. Okay. Post-op care, this is kind of some routine things. We use a lot of gel foam. I debride them back every couple of weeks after we do a canal wall down. And then I usually see them back twice a year after they've healed and things have granulated. I think Tashneen probably likes to obliterate the mastoid, right? So some people will obliterate. They'll take the periosteal flap and they'll lay it down inside to kind of partially obliterate it. Or some people will put different things in there, fat, different things to kind of maybe obliterate so the cavity is smaller. I don't typically do that. I found I've never really needed to. I just kind of leave that open and it creates a nice space. And then other things, again, this just kind of comes back to the idea of reconstruction, right? You may have limited options with recon with the circular chain. Sometimes we have to overclose the ear. That's very rare. But reconstructive options for hearing are a little bit less. This is the obliteration. The goal here is to try to make it a smaller cavity, or if we're overclosing for a different reason, maybe it's from CSF leak or cochlear implantation and the ear is not healthy or they had a previous wall down. So those can create issues if you've obliterated those because you may have to monitor those. You've got to be sure if you obliterate a cavity that there's no potential skin in the mastoid, right? Because you could be creating a really dangerous situation if you didn't get all the skin out and you obliterate that and you close it off. That could be a big issue later. Okay. This is the ear canal overclosure. This just shows that a nice way to do it. Some people used to do it with the old belly button, where they would take the anterior canal skin, posterior canal skin, flip both of these out, and then sew these back together like this. Creates almost like this everted flap of tissue. Kind of is not very aesthetically appealing. So what I typically do is we cut out the backside of the natal skin and the backside of the ear canal. And then you take the anterior canal skin up to the bony cartilaginous junction and you flip it out and you sew it to the natal edge. And so you get this really nice, aesthetically pleasing closure that's really heals well. And in the natural shadows of the ear, you can actually see that the ear canal has been overclosed. Okay. That's it. The point of this is one of my old residents. The point of this here is we were doing some teaching. Lily, you saw when I'm drawing stuff. We were drawing a translab approach, right? There's the internal auditory canal. There's your superior trough, inferior trough. There's the ear canal, sigmoid. Point of this drawing is draw things. When you're learning anatomy, if you can't draw it, you don't really know it. I was taught that early. Like if you can't draw something, you don't have to be the best artist, but you should still be able to draw something. You don't fully appreciate the anatomy. So draw things when you can. All right, thanks for sticking with me on that. I hope I didn't go over time, but happy to answer any questions or comments.
Thank you, Prof. Anyone who has a comment on the floor? Yeah.
Well, thank you for the very nice summary, actually.
Yeah.
It's good to have some pathology in again.
Yeah, it's a lot to kind of cover in an hour, but I do have a question though. So, Lillian, second look surgery you did in Kenya. Will you do second look surgery or no? Some of the cholesteatoma, you operated on them.
Yeah.
You did intact canal wall tympanomastoidectomy, pretty big disease. You cleaned it all out. You rebuilt the drum, and then they go away. They heal up. They come back. What's the long-term plan for that patient? How do you follow them, or what do you do?
So most of the times you want to consider several factors. You want to consider the resources available, and you want to consider the clinical presentation of the patient, and also you want to follow up the patient, how they are doing with their treatment. So if you have all the resources available, you have an option of either taking them back to theater for an surgery, or possibly following up the patient by doing diffusion weighted MRIs to check for recurrence of disease. Yeah. But when you are limited resources and you don't have available theater time, the patient might not be, might not be good to follow up. That is repeated surgical follow-up. Then maybe you can either use the clinical presentation if they come back with a recurrent, maybe they come back with otorrhea that has recurred, or if they come with the deterioration of their audiometric results. So they probably had a good hearing, and they come back with either the worsening of the conductive hearing loss, with a wider airborne gap from the postoperative one, or if they come back with symptoms of a fistula, like they come back with dizziness, signs of canal, signs of a fistula, then you suspect and you can take them back to theater. So it's all dependent on the resources you have, the presentation of the patient, and what you can do. You can also do a repeat CT scan if you're suspecting, but then again, with a CT scan, the question is how to differentiate between granulation tissue and recurrence for the cholesteatoma. So you might be forced to still do another. Yes.
Does anybody have any questions from the
Yeah, anyone with any comment or questions from the online platform? I don't see anyone with any question on the chat as well. Yeah, so thank you very much for attending this morning's meeting. We will see you on our next meeting. We'll announce when we'll have it. Thank you very much. I'm gonna end the meeting now.
You can see that once a week?
Once.
There's a chart.
There's a chat comment.
Oh, there was a chat comment?
Okay, it's just somebody appreciate. This is Thomas, one of our AMOs in New Somerset.
Oh, okay.
Yes, thanks, Thomas.
Great.
Okay.
All right, thanks, guys.